Welcome to this lecture. We'll be talking about the fetus, placenta, and amniotic fluid. I'm Dr. Adeni Olumide, a senior registrar, Department of Obstetrics and Gynecology, Obafemi Awolowo University Teaching Hospital in Ile-Ife. The expectation at this lecture is that at the end, we expect that you should have basic understanding of fetal development, to be able to discuss fetal growth, and then to also understand the structure and function of the placenta. And we expect also that you'll be able to identify the role of the amniotic fluid in fetal development and some of the problems that may be associated with the amniotic fluid. So let's talk about the fetus. There has been a lot of development in understanding how the fetus grow. And the field of perinatology or fetal medicine is broadly dedicated to this area, understanding the physiology, the pathophysiology of the fetus, the development and environment. So as a result of this, the fetus has also been elevated to a status of a patient that also can be measured, treated like every other patient. The journey to human development begins as fertilization. That is where two halves come together to make a whole. These two halves are the male gamete, which is a spermatozoon, and the female gamete, which is the oocyte. And these gametes unite in a process that we call fertilization, resulting in the formation of a zygote. So it is this zygote that now go ahead to develop into embryo, fetus, and every other thing that product of conception. So gametogenesis, that's the process by which these gametes are formed. The gametes are derived from the primordial germ cells, which are formed the epiblast, and they move to the yolk sac, arriving at the gonads at about the 50th week. During this migration, the gonads of the gametes, the primordial germ cells, they begin to proliferate by mitotic cell division, still containing their diploid number of chromosomes. But when they get to the gonads, they begin to differentiate and then undergo meiotic cell division. So the gametes undergo two kinds of cell divisions, the mitotic cell division and the mitotic cell division. The important thing to note is that the mitotic cell division gives rise to 2 daughter cells, while the meiotic cell division gives rise to 4 daughter cells. So this is just a diagram showing the process of mitosis, and then this one shows the process of meiosis. You notice that in mitosis there are 2 daughter cells, and in meiosis we have 4 daughter cells. And by the end of meiosis, the daughter cells have half of the chromosomes of the original parent cells. So that's they are called. So the cells, the chromosome number is haploid compared to the for those in mitosis or oligomitosis that they have a diploid cell number. So this is diagram just showing the process of spermatogenesis, where the primordial germ cells continue to divide and differentiate to ogonium, and then from there to primary spermatocytes, secondary spermatocytes, and then to spermatids, and then they differentiate to become spermatozoa. And then this also shows the process that goes ahead in oogenesis for the female. So each gamete, like I said, contains haploid number of 23 chromosomes, and the union of the gametes at fertilization now restores the diploid number of chromosomes, that's 46. Now, when there's a deviation in the error in this process of gametogenesis, it may lead to one of the daughter cells not having a complete set of chromosome, or missing or having one extra chromosome. Sometimes the chromosome may break and get attached to another chromosome, and then sometimes the piece of chromosome are broken and lost. Now we need to talk briefly about ovulation. Just before ovulation, the oocyte completes the first meiotic division, and then they get arrested at the metaphase of the second meiotic division. But at ovulation, the oocyte, which is surrounded by the zona pellucida and the granulosa cell, which is called the cumulosome forus, they are extruded from the Graafian follicle into the peritoneal cavity, and this extruded oocyte is now picked up by the femoral end of the fallopian tube, and it is through this tube that the oocyte is transported to the uterus. When coitus take place, there are many, the millions of spermatozoas are released into the vagina. They migrate to the cervix, or through the cervix to the fallopian tube to meet with this oocyte, and then they undergo fertilization. And this takes place at the apical region of the fallopian tube. There are many spermatozoa cells that contest, for the hand of the oocytes in marriage, so to speak, but only one usually is successful. And the phase of fertilization can be divided into three. There's a phase of penetration of the corona radiata, that's the granulosa cells surrounding the oocyte, then they penetrate the zona pellucida, and then there's a fusion of the oocyte and the sperm cell membrane. So this on the left is showing the many cells, many sperm cells, covering the oocyte, juggling to be the one to fertilize. And here we see the one that is successful, that is piercing through the zona pellucida to get to the oocyte membrane. And then at this stage, there's already fusion of the two gametes to form a zygote, and then the haploid number of chromosome is restored to diploid. And so this is, the diagram or picture showing after fertilization, the pronucleus of both the oocyte and the spermatozoa lying side by side. And then this is when they have started dividing. This is two-cell stage. And then from there, the oocyte from fertilization move down to the uterus, and by the 6th day, they are already in the uterine cavity, and by the 8th to 9th day, implantation of the fertilized ovum is taking place. So the zygote, which is what becomes transformed into the human fetus, and then the baby that is eventually delivered, and they undergo 3 stages. There's a germinal period, that's usually the first 2 weeks after conception, then the embryonic period from the 3rd week to the 8th week, and then the fetal period from the 9th week then of conception to birth. So as the zygote journeys to the uterine cavity, it undergoes mitotic division, increasing the number of cells, and these cells are now known as the blastomeres. When it becomes about the 16th cell stage, which is called the morula, the cells, inner cells, are compacted together to form the inner cell mass, and then the surrounding cells, outer cells, form the outer cell mass. It is the outer cell mass that forms the trophocyte that eventually develops into the placenta, while the inner cell mass eventually develops to become the fetus. Okay, so this is the cell. They have been compacted. This is inner cell mass, and this is the outer cell, which it would differentiate to become a trophocyte. In the process, there's a cavity inside of the cells, and by this time, it is now called a blastocyst. And the trophocytes overlying the inner cell, is what will now penetrate into the endometrium in the process of implantation. So the 2nd to 3rd week, the cells of the inner cell mass differentiate into hypoblast layer and the epiblast layer. That's when we have the bilaminar disc. Some cavity appears in the epiblast, which now gives rise to the amniotic cavity. Cells from the epiblast migrate towards the primitive strix, invaginates inwards, and then gives rise to a 3rd layer in between the epiblast and the hypoblast, and this is the process of gastrulation, and it is in this process that the 3 germ layers are formed. Okay, so this again showing this is implantation already taking place. This is the epiblast and the hypoblast layer, and then the cells are migrating from the epiblast down in between the epiblast and the hypoblast, and here they're already forming the 3rd layer. So from the 3rd week to the 8th week, that's the period of organogenesis. Each of these three germ layers, which are the ectoderm, the mesoderm, and the endoderm, they give rise to a number of specific tissues and organs. And so by the end of the embryonic period, the main organ system had already been formed. The major features of the external body are also recognizable by the end of the 2nd month. Amniotic fluid is already seen surrounding the baby. The face and limbs are taking shape. All right, so this is the fetus at 4 weeks. You can already see some features taking place. The heart already formed. This is the what eventually comes the vertebral column, and the brain already forming. And again, this is another picture showing it. You can see the features are already showing the amniotic fluid surrounding the fetus. Again, this is just enlarged and a labeled diagram of the structure of the fetus at about 4 weeks. At about 6 weeks, this is what we find. Fetus still developing more of the structures are seen. It's about 13 millimeter in length when you measure the crown rump length, and then by the 7th week that has increased. So these are pictures just showing the various stages at the organogenesis stage, and we can see that by the 8 weeks, even the fetal limbs and toes can already be seen. Again, so from the 3rd to 9th month, this is known as the fetal period. This is characterized by maturation of tissue, organs, and rapid growth of the body. By the 3rd month, the face becomes more human-looking. The eyes move from the side to the ventral aspect of the face. The hair comes to life in their definitive position. All the internal organs are present by the 3rd month, but they are not ready to function at the moment. And then the limbs are also present. So we see the fetus at the 3rd month here. You can see the legs already recognizable. All the structures are formed already. So from 4th to 5th month, the fetus lengthens rapidly. The weight of the fetus increases. It is now covered with hair that is called lalungo hair. We may be able to see the eyebrow, and the hair on the head is also visible. Movement of the fetus can be felt by the mother at around this time. The heartbeats can be picked at around the 4th to 5th month, either by a handheld Doppler device. And then they have a protective coating on their skin, which is called the vernix. At this point also, the eyes can be seen opening and closing. Okay, so this is the fetus at about the 4th to 5th month. And it's taking more shape, like looking more human. All right, you can see the eyebrow already visible by the end of the 4th month, and then about the 5th month as well. So from this 6th to 7th month, the lungs are filled with amniotic fluid. It's said that about this time the fetus can hear, so their optic system is already working. There is fat deposition under the skin. They are active, so they can feel the kicks and all that very well, and they take time to rest as well. And so you see, this is the fetus, more developed, much more developed, looking more like a newborn baby. The 8th to 9th months, they are well rounded now because of deposition of subcutaneous fat. The skull is the largest circumference of the body, and that's the reason why it's important when you pass for the body passage to decide its passage through the birth canal. The weight about this time is about 3 to 4 kilograms, and they have a length of about 50 centimeters. The sexual characteristics are pronounced. The testes at this time should be in the scrotum. Lightning occurs in getting ready for delivery, and so you can see at about 8 months the baby is said. The scrotum, the penis can be seen. This is a male fetus, and then this is just the baby after born. So we just looked at the general development of the fetus, and like I said earlier, the fetus is now regarded like a patient, so they have a right of their own, so to speak, and there are various ways to assess the health of the fetus and detect the problems with them. The problems that can be associated with the fetus are numerous, but just to a bit summarize and classify them, they could be as a result of chromosomal or genetic abnormalities. Remember I talked about in the process of meiotic division, this process of fertilization and then subsequent divisions, mitosis that takes place. There can be problems in the arrangement of the chromosomes, and some genetic materials may be lost. So they can have problems like trisomy 21, which gives rise to Down syndrome. They can have Turner's syndrome, Angelman syndrome, and others. These problems could also be functional. Fetus could as well have anemia. They could have arrhythmias. They could have thyroid disease. They could have congenital adrenal hyperplasia. The problems could also be structural, like congenital heart disease, neural tube defect, like spinal bifida. They can also have ventral wall defect, like omphalocele. So prenatal diagnosis, there's an area of fetal medicine called prenatal diagnosis, which is dedicated to identifying the functional or structural abnormalities in this developing fetus through invasive and non-invasive techniques. Some of these invasive techniques are basically used to detect chromosomal abnormalities, and then some for structural abnormalities. For example, chorionic villus sampling, amniocentesis, cordocentesis, and fetoscopy. In chorionic villus sampling, at about this is done at about 11 to 13 weeks, where a sample of the placenta is taken for karyotypic and genetic analysis. Amniocentesis is done after 14 weeks. A sample of the amniotic fluid is taken, and then also cells in there are cultured for genetic and chromosomal analysis. Chondrocentesis, also known as fetal blood sampling, it's when the fetal blood is aspirated, and this also can be used for a lot of diagnosis and analysis. And fetoscopy, that's using forms of endoscope to make some diagnosis. The non-invasive method, which is the current thing that is being done now to detect abnormalities, though basically they are used for structural abnormalities, especially with the advent of ultrasound. It had helped with a lot of diagnosis. So we have various forms of ultrasound, the 2D, the 3D, the MO, the Doppler. These have been put into use to detect any of these fetal abnormalities. Sometimes magnetic resonance imaging may be needed to also help to make diagnosis. And when these diagnoses are made, then treatments can be offered. So interventions are developed to alter the course of selected fetal anomalies and conditions. So the management could either be expectant, and then since we have diagnosed and the ones that are compatible and they have treatment after delivery. So we just watch, deliver, and then get this treatment afterwards. Sometimes we may need to end the pregnancy or accelerate delivery. Some medical treatment can be given through the mother, and then surgical therapy. Such surgical therapy may be percutaneous, fetoscopic surgery, open fetal surgery, or what we call ex utero intrapartum treatment. So that's about the fetus. So let's really talk about the placenta. The placenta is a fetal maternal organ defined as intimate apposition or fusion of fetal organs to maternal tissue for physiologic exchange. The human placenta is hemochromia because the maternal blood contacts the trophoblast. If you remember, while I was talking about the process of fetal development, we talked about the trophoblast. The trophoblast are formed by the blastocyst as early as 72 hours after fertilization. They proliferate, and then they invade the decidua soon after implantation, if you remember the slide all the time. And then the invasion of this endometrium proceeds until the maternal blood vessels are invaded to form the intervillous spaces. So the trophoblast, they differentiate into two layers. They have the cytotrophoblast and the syncytotrophoblast. The syncytotrophoblast is like a multicellular layer that are derived actually from the cytotrophoblast, and then the vacuum forms in this spaces formed within this syncytium of syncytotrophoblast, which forms lacuna. So there's a lacuna stage of trophoblastic development, and then as the process goes on, this syncytotrophoblast, I beg your pardon, erode the endothelial lining of the maternal capillaries, and then this is in this process the heteroplacental circulation is formed. So this is just a diagram showing this is the cytotrophoblast, and this is the syncytotrophoblast already invading into the maternal blood vessel. This is the lacunal system that is already formed. So in this process, the heteroplacental circulation is already formed. And then the cytotrophoblast, they proliferate, forming columns into the syncytium, and this gives rise to the primary villi. And then mesenchymal cells from extra embryonic mesoderm also invade this column, and at this point it is now called a secondary villi. When the mesoderm differentiates into blood cells and blood vessels, then it is called a tertiary villi, and then angiogenesis seen. Right? So this is the primary villi, this is the syncytotrophoblast, and these are the cells of the cytotrophoblast. These are transverse section of the villus, and then this is the mesoderm already in the core of the cytotrophoblast, and then vessels already forming in the mesenchyme. So at this stage, by the time the tertiary villus or villi are formed, then heteroplacental circulation is already in place. Most of these villi will arborize and entering freely into the intervillous spaces. Each trunk or main stem of the villi constitutes a placenta lobe or a cotyledon, and these are what constitutes the functional unit of the placenta structure. All right, so we can see here blood vessels already formed in the mesoderm, mesoderm already, the cytotrophoblasts already proliferating, even forming a layer over the cytotrophoblasts. The anchoring stem, and then the branching of the villi into this sinusoid or intervillous species. So this is a placenta already formed, with this cord attached, umbilical cord attached. So just a brief structure of the placenta. Human placenta now, it is discoid. Its diameter is about 15 to 20 centimeters, weighs about an average of 500 grams at birth, or about 1/6 of the weight of the fetus. Its thickness is about 2.5 centimeters at the center, but it tapers gradually to the periphery. It is most of the time location is in the upper segment, which is in normal position where the fetus should be in the uterus. Sorry, the placenta should be in the uterus. It has two surfaces. There's a fetal surface, and then there's a maternal surface. Okay, so this is the maternal surface. This is where the cotyledons are fine, divided into many cotyledons, about 15 of them. And this is the fetal surface. It is smooth. It is glistering because of the covering of the amnion. So the functions of the placenta takes the role of many of the functions of the organs in the in a developed woman. So it functions, it does circulatory function, endocrine functions. They secrete a lot of hormones, progestogens, progesterones, estrogen, human placenta lactogen, human chorionic gonadotropin. It also serves a nutritive function. Oxygen and nutrients are transported from the maternal blood to the fetus. The various methods of oxygen and nutrient transfer is listed here. They also form barrier function against noxious agents that may be circulating the maternal blood, and they also serve immunologic function. This is just a table showing hormones that are produced by the human placenta. Now, there are variants of shape and structure of the placenta, and it's important that we know them because they have clinical significance. So you could have subcentrate placenta in which there's an accessory lobe. There's a main lobe and there's an accessory lobe. So for in this one, there's a main lobe. This is a main lobe, and then there's an accessory lobe here. And sometimes when these occur, it can give rise to retained placenta because the main lobe is delivered while the retained this accessory lobe is left inside. Or sometimes, if the distance between the two of them are wide and vessels have to run from the main lobe to the accessory lobe over the placenta, then that may lead to mucous vasa previa and lead to fetal demise when the membranes rupture. Then we also have the bilobe placenta. This is when the placenta is divided into two equal halves. And it can be multi-lobe if it is more than two. Then this is circumvallate placenta. And then this is the batodur. The attachment of the cord is at the edge of the placenta. So that's a batodur placenta. Then there could also be problems or abnormalities of implantation where, one, there could be adherence of the placenta. The placenta is supposed to just separate easily after delivery of the fetus, but in certain situations known as the placenta accreta syndrome, the placenta are mobilely adherent to the uterus. And there are three types or still categories. You can placenta accreta when there's an inversion of the endometrial bridgement membrane. In placenta accreta, the placenta invades into the myometrium, and in pachytra, it invades beyond the serosa of the uterus. Then we could also have placenta previa, which is where the placenta is located in the lower uterine segment. Remember, I said that in more than 90% of cases, the placenta is located in the upper uterine segment. Then occasionally we have placenta membranacea. This is where the whole of the uterus is covered by the endometrium is covered by placenta, and that happens when the chorion fundusum and chorion levae form a placenta. And this can lead to placenta previa, retained placenta, and then postpartum hemorrhage. So this is a diagram showing the different classification of the placenta accreta syndrome. Then sometimes, just like we can have tumors in adults, we can have tumors in the fetus, and especially in the placenta. So we can have chorioangioma. It's a benign neoplasm of the placenta, found in about 1% of placenta. It may cause arteriovenous shunting of blood away from the fetus. Complications include postpartum hemorrhage, preterm delivery, fetal growth restriction. Right, so it's just important for us to note that. So let me quickly talk about the amniotic fluid. Amniotic fluid is that fluid that covers the fetus, and during the embryonic period, it is derived from both fetal and maternal factors such as water from maternal serum, coelomic fluid, and from the amniotic cavity. But later in gestation, the fluid is largely produced by the fetal urine and lung secretion, and this has important implication. So if there's anything that affects the fetal urine production, then it will lead to problems with the amniotic fluid, and it's approximately about 98% water. So amniotic fluid is tightly regulated. It is produced by various means: transudation of maternal serum across the placenta. It's produced from transudation of fluid from the umbilical cord, secretion from epithelial surface of the placenta, from permeable skin, the skin of the fetus before keratinization takes place. But more importantly, like I said earlier, it is produced from fetal urine and then also the fetal lung, and usually removed or recycled by fetal swallowing and then intramembranous absorption of water and solid. So if there's a problem with production of urine, or there's a problem with swallowing of the fetal swallowing mechanism, then this will lead to problems with the amniotic fluid. So it's circulated around the fluid and it's replaced about every 3 hours. The volume, it's about 50 mils at 12 weeks, and by 20 weeks, 400 mils, and at time it's about 800 to 1 liter, and thereafter it then begins to diminish. It's faintly alkaline, has a specific gravity of 1.010. The amniotic fluid osmolality falls with advancing gestation, and then the color usually said to be pale straw color because of the presence of exfoliated lanugo cells and epidermal cells from the skin. Usually looks turbid because of the presence of the venous caseosa. There could be abnormalities with this color, and this sometimes help in making some diagnosis. If it is meconium stain, it may suggest some fetal distress. It may be golden color if there have been resource incompatibility and there has been excess hemolysis of fetal red cells and production of bilirubin. It can be greenish yellow in post-maturity syndrome, and then it can be dark colored if there is concealed hemorrhage, and dark brown if the fetus are died in utero. So like I said, it's composed mainly of water. It could have some solid components, organic component like lipids, protein, then inorganic components, sodium, chloride, potassium, and then suspended particles, like I mentioned, lanugo here, exfoliated squamous cells from the skin, the respiratory tract, and the bladder. They function basically to serve as shock absorber, protecting the fetus from injury. It also helps to maintain an even temperature, allows for growth and movement of the fetus, and also help in dilatation of the cervix during labor. Now, I mentioned that one of the objectives of this lecture is to talk about the problems that can be associated with the amniotic fluid. So the problem can either be that the fluid is too much, in which we call polyhydramnios or hydramnios, or it is too small, which is oligohydramnios. How do we assess this? Usually done sonographically, and there are two semi-quantitative methods can be used, whether we use the amniotic fluid index or the single maximum vertical pool or the single deepest pocket. And the normal value is for maximum vertical pool is between 2 to 8 centimeter, and for the amniotic fluid index between 10 and 25 centimeters. So oligohydramnios, that is when it is too small, that is when the amniotic fluid index is less than 5, or the single deepest pocket is less than 2 centimeters. The causes are many. It could be chronic fetal hypoxemia from growth restriction. It could be because of postpartum pregnancy, because as the pregnancy advances beyond term, the volume of amniotic fluid reduces. It could be because of repetitive cord compression. Then fetal anomalies. Remember, the amniotic fluid is basically at later gestation fetal urine. So if there are renal agenesis, renal abnormality, posterior rectal valves, reteric heteropelvic junction obstruction, this can lead to reduced amniotic fluid. It could also be found in chronic use of non-steroidal anti-inflammatory medications. If there's premature rupture of membrane, very important for us to know. And then in twin pregnancies, if there's twin transfusion, the donor twin will have oligohydramnios. The complications of oligohydramnios, pulmonary hyperplasia in the fetus, they could have limb deformity. In labor, they could have variable and late deceleration. This may lead to cesarean section because of non-reassuring heart tracing. And there's also a higher risk of perinatal mortality depending on the cause of this oligohydramnios. For treatment, depending on what they discuss, some are talked about amnio-infusion as one way to treat oligohydramnios. Then we have polyhydramnios, that is when the amniotic fluid index is more than 24-25 centimeters and the single deepest pocket is more than 8 centimeters. It could be mild, moderate, or severe, as shown on this slide. The causes are maternal conditions, rhesus immunization, diabetes, mellitus. So, and I think this is very important for us to know. So when you see a pregnant woman with polyhydramnios, we should always screen the woman for diabetes mellitus. There also be fetal conditions like cholangioma, like we talked about, circumvallate placenta, and then fetal conditions if there are twin-to-twin transfusion. Remember, for oligohydramnios will be found in the donor twin, while polyhydramnios will be found in the reciprocant twin. Then if there are problems with the fetal gastrointestinal system, esophageal atresia, omphalocele gastroschisis, this can also lead to polyhydramnios, and some fetal lesions and encephaly has been so much associated with polyhydramnios. Then skeletal malformation, fetal tumors, cardiac disease, genetic disorders, and sometimes you have non-immune fetal eye drops. Usually present with overdistension of the uterus. When we measure clinically, the uterus is usually larger for death, and then it can present with compressing effect on the intrathoracic and intra-abdominal organ. It may cause dyspnea and respiratory distress. Back and abdominal discomfort has been reported, and sometimes they're predisposed to nausea and vomiting, and then edema of the lower limbs. So the complications include preterm labor, malpresentation, dysfunctional labor, and they can also predispose to postpartum hemorrhage through the route of uterine atony. Treatment again depends on the cause. Some have talked about the use of amnioreduction, to reduce the volume of fluid and then give some relief to the woman. The role of indomethacin, it's a bit controversial in managing this patients. So we've talked about fetus, we've talked about the placenta, and now we've talked about the amniotic fluid. And it should be noted that technology has actually helped in improving our knowledge of the fetus and its development. So the advent of technology has helped tremendously in improving our knowledge of the fetus and its development. And problems in needs development can now be identified while in utero and can also be managed. The role of placenta in development of certain fetal and maternal condition has been elucidated. The field of fetal medicine is ever increasing in scope, and I hope that this lecture has spurred our interest to learn more about fetal development and all its associated problems. Thank you very much for listening.